Sir, we are already live. Can we begin?
Yeah, no problem.
Yeah, thank you so much, sir. Good afternoon to all the viewers who are here with us for today's session. I am Batul from IGCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our eminent speaker for today's session. Sir needs no introduction, but it's my pleasure and honor to introduce him at our platform. He is none other than a very renowned HIV specialist, Dr. Uday Kumar Jadhav, sir. Sir is MBBS, CHIV, PGCR, AFIH, infectious disease consultant, in charge at the Art Center, L&T, MDSCS Mumbai, owner of Life Care Clinic, Total Care in HIV AIDS, Aurangabad, Maharashtra. Sir is also attached to Panacea Super Speciality Hospital, Aurangabad, Maharashtra, and is also the consultant at Shraddha Hospital and Critical Care. With the help of Sir, we'll be taking a close look on today's topic, which is oral manifestations in HIV. Before moving on to today's session, let us have a brief look on what the topic says. Oral manifestations are common in people living with human immunodeficiency virus. These manifestations can occur at any stage of HIV infection and can be indicative of the progression of the disease. Oral manifestations in people living with HIV can include oral thrush, hairy leukoplegia, oral ulcers, and periodontal disease. HIV-related oral manifestations can also impact a person's quality of life and nutritional status. We'll be knowing and we'll be learning more about the topic with Sir's wonderful inputs. So now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his precious talk to begin. Sir, over to you.
Thank you very much, Batul. Good afternoon, everybody. Today, we are going to start a system of learning from oral manifestation in HIV. As you know, HIV, or also called as human immunodeficiency virus, is one of the infections that is a pandemic all over the world. It is a sexually transmitted disease and also can be blood-borne. The infection characterized by gradual decline in cell-mediated immune function and complicated by a wide variety of opportunity infection and neoplasm. First to be identified was in the homosexual healthy man in 1983 in USA, and then it was a characteristic thing for all the people over the whole world. Now, as we know, the diagnostic test for HIV was discovered in 1985, and from then we could see that not only every country or region, even the smallest of the villages in the whole world, is being infected with the people with HIV. The people with HIV, as we see, are spread all over the world, and not even a single part or single area is remaining away from this particular infection. So this is a pandemic. As we know, the HIV, there are two types of infection. There is HIV-1 and HIV-2. What is the difference between HIV-1 and 2? They have similar serological pattern, but only some kind of proteins are changed. Where is this seen? HIV-1 is mostly seen all over the world, leading to AIDS. There is acquired immunodeficiency syndrome. It has three subtypes, M, O, P, and most common type is M. HIV-2 is very rare, but it's seen in African countries and Southeast Asian continents, but most commonly, less commonly, we shows AIDS. What is the etiology? The HIV, it is sexually transmitted from heterosexual regions, or it can also transmitted from females, mostly from females to males. Homosexual transmission also contributed most of the things. There are a lot of blood transmission issues that help there unless we sort a policy for tracking the infections in the blood. There are needle pricks, and also perinatal transmission was very common through placental while delivery or even while lactation. It was seen. What are the risk factors that are pertaining to this particular infection? The number one risk factor is multiple sexual partners. Secondly, unsafe sex or sex without any latex condoms, or improper blood transmission in which the blood is not tested, a pregnant lady diagnosed with HIV, and some occupational hazards can also be contributed to these risk factors. This is the virus picture that we see. It is the RNA virus, which is composed of outer GP120 and the GP41, and the part of this is the reverse transcription enzyme that adds the changing of the DNA of human DNA, double-stranded DNA into single-stranded RNA. So what is the pathogenesis? HIV targets the CD4 cells. What are CD4 cells? The immune cells. The GP120 will bind to CD4 cells and the co-receptors and the virus receptors, T lymphocytes, and then the mRNA, with the help of reverse transcriptase enzyme, will convert it into proviral DNA, and then the proviral DNA will integrate into host DNA and activate the cell. So by this activation, the proteins for the immune response will get activated, helps the virus to multiply. These replicated virus will replicate with different strains and targets and different types of T cells. The replicated virus will, which are targeting the CCR5, will enter into lymph nodes and then lead to lymph node invasion as well as opportunistic infection. So this is the basic pathology we should know before entering our current topic. So this is how it goes and binds and physiological dispute. Inside the cell, we have CXCR4 and CCR5, and macrophages monocytes are already indicated this, and this leads to the infection. When it enters, this double-stranded DNA becomes a single-stranded RNA, and then the retrovirus will come. This is how it goes. Now we'll come to the clinical features. The 10 to 50% of HIV patients, as we know, are asymptomatic. They will not show any symptoms. So people feel like anybody getting infected with HIV or acute HIV syndrome can have symptoms, but it's not true. Most of the patients do not have symptoms. The highest frequency symptoms are usually occur from the peak viremia. When the virus returns, it is lower threshold. When it rises up, goes to a peak, then we have some symptoms. The symptoms are recurrent fear, lymphadenopathies, some recurrent upper respiratory infection, weight loss, rash, myalgia, arthralgia, neurological like headache or diarrhea. But these are only in the 50% or less than that. So these are the acute rectal syndrome, consists of fever, radiopathy, pharyngitis, rash, headache, diarrhea, myalgia, hepatosplenic weight loss, and all lots of things. So there are 4 stages. Stage 1, which is asymptomatic, and stage 2 with weight loss more than 10% and minor infection like dermatitis, fungal infection, herpes zoster in last 5 years or any other thing. Stage 3 with weight loss more than 10% of it. The diarrhea of unexpected chronic origin for more than 1 month, or fever or organization or the heroin or permanent tuberculosis in the past year. Also, in stage 4, there is wasting disease, there is PCP pneumonia, toxoplasmosis, cryptosporidiasis, cryptococcosis, CMV. These are infections we see. These are the major clinical stages that are seen as per the WHO. Now, as we know, herpes simplex virus infection is an infection that can come or remain for 1 month of selection. They can have PML, they can have other kind of infection, candidiasis, or esophagus, trachea, bronchi, lung, and also some kind of atypical mycobacteriosis. So these are the few infections that we see. But as you know, today's topic is oral manifestation in HIV. So we will shift our focus to this. And as we know, most of us know the basics of HIV. So, but we today will understand how to diagnose or how to manifest, how to understand the infection in HIV, the oral one, which is as the most common practitioner we see. So more than 90% of patients have at least one oral manifestation in their lifetime, and are always accompanied by symptoms. There are a variety of appearances, and these particular infections, if seen, we can understand that person may or might be suffering from any kind of infection or HIV disease, and that should be tested. So if we go to the next slide, you see what are the impact of oral conditions in HIV patient. Number 1, there are high rate of oral manifestation. Oral lesions can be of changes in HIV condition. They can be related to ease of access to identity of lesions in those practice. The potential impact is also on the systemic health of the patients, and also the potential impact is also the quality of the life of the patient. So screening the patient with the oral manifestation is of prime importance in a general clinic. So what are the type of lesions that is seen in oral HIV infection? There are 2 types. One that is neoplastic, that is commonly seen, which consists of carpus sarcoma, which is most common in African countries, lymphoma, or carcinoma, and other infections that we see are HIV, necrotizing ulcerations of the gingival part or the salivary glands that can lead to xerostomia, or there can be abnormal mucosal pigmentation of the infection. So these are the few pictures we can see. There is necrotizing ulceritis or gingivitis, gingival erythema. You see the redness in the base of the gingiva, and non-Hodgkin lymphoma we can see. We can see erythematous rash, pseudomembranous spot, hairy leukoplakia, and also Kaposi sarcoma. These main 8 manifestations are common in the oral HIV, and we should definitely look for them so that we get a guiding path and we can diagnose and treat the patient. So what are the most common infections that we see in the oral part? We see the viral infections, we see the bacterial infection, and also the fungal infection. When we come to viral infection, the most common infection is the herpes simplex virus that is very commonly seen. And most of the time, if you do not respect the oral part or oral cavity, you will miss it. There can also be varicose zoster virus or the herpes part. There can be pox virus, there can be human papilloma virus, there can be Epstein-Barr virus, cytomegalovirus, and also the HIV/AIDS, that is Kaposi sarcoma. In fungal infection, most of the time, the commonest we see is candidiasis. The candida is a very common cell, and this can lead to infection causing pseudomembranous type of candidiasis or erythematous type of candidiasis or angular cheilitis. The very commonly seen this. We can also see systemic fungal infection in some patients. There, we also have bacterial infection, most commonly the staph aureus, very commonly seen in the ICU patient. Okay, there can also have linear angioedema or necrotic ulcerative periodontitis, tuberculosis, bacterial angiomatosis, MAC, and also syphilis. I'm mentioning syphilis because right now we have a great bout of syphilis infection coming to our practice from last gap of 100 years. Before 100 years, we had syphilis as rampant as HIV, but in the last few years or the last century, syphilis was being treated properly with antibiotics. Penicillin was the key, but now since penicillin is no more in use or very less in use, we are again seeing this. We also have systemic infection like tuberculosis, histoplasmosis, coccidiosis, blastomycosis, penicillosis, and protozosis as per geographical or regional variations in patients who are suffering from HIV. These are the various complications that the chart we have. CD4 less than 500, more than 500, less than 250, less than 50. There are various kind of infections which are related to dermatological, respiratory, nervous, hematological, other parts of the body. But today, as we are focusing on the oral manifestation, we'll only focus on that. So first going to the herpes simplex virus. What is herpes simplex virus? It's a double stranded DNA virus. Herpes viridae. There are two types, 1 and 2. These are having sensory neurons. It are trigeminal and sacral, becomes home for herpes. They lay there, stay there, become their they lay there stagnant, and then they come out when the immunity is low. So oral, labial, genital herpes simplex lesions are typical in appearance. On immune suppression, lesion may progress to chronic deep ulceration involving the anal region, genital region, and as well as the oral region. So chronic perianal ulcers being associated with herpetic colitis, but HSV in the oropharynx extend to esophagus, even lead to odynophagia. Progressive herpetic whitlow of nearly entire digit is also one of the parts we can see to identify the infection in the oral cavity. There are also non-primary HSV infection that can disseminate. They can disseminate hematogenously, resulting hepatitis, pneumonitis, keratoconjunctivitis, encephalitis, and also disseminated skin infection. So this is a characteristic herpetic infection that we see on skin, and this is what we see in the oral cavity. As we see, the oral cavity infection is erythematous and not very easy to diagnose. But regular screening of patients and practice helps us to see this kind of spots which can be diagnosed as per herpes test. So all the diagnostic values we can go scraping, we can go viral DNA, PCR, antibodies, and treatment, as you know, is acyclovir, 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 even for 7 to 10 days. And in immunosuppressed patient, we can also increase the dosage to 800 milligram 5 times a day daily for more than 15 days also. So, bacillus zoster virus that we see, this is something which has incubation 14 to 21 days. It can be persistent hyperkeratotic bullous lesions and also be ulcerative, multidermatomal, and present all over the body. These treatment, this diagnostic value is by Zangspear clinically, and also treatment is same. These are the herperic zoster, and I'm just giving it because we have to know simplex and zoster had two variations. Now coming to the pox virus. Pox virus is known to cause 20% of symptomatic HIV infections. The most common is molluscum contagiosum. Molluscum contagiosum, as we know, the infection is amphibian papule shape and larger than 1 centimeter. Previous to the ART era, we used to see a lot of molluscum contagiosum solitary or in groups. But right now, in the ART era, we are not able to see much of this. This is how the molluscum contagiosum seems. The most common is the human papillomavirus. As we know, HPV is one of the common general population infection with people living with HIV. HPV, human papillomavirus, is a carcinogenic virus and that can lead to various kinds of carcinogens as well as it can form multiple verrucae. It can form on the face, lip, genitalia, and also in the large flaps. Oncogenic HPV types are 16 and 18, and they are isolated from endogenous region. And even as we know, oral sex is becoming more and more common. The oral cavity also, we can see HPV infection. So HPV infection in the oral cavity are most commonly with having gingival infection, or in the they can have verrucae in the gingiva causing gingivitis. Next is the Epstein-Barr virus. The Epstein-Barr virus causes oral hairy leukoplakia. It is a lesion specific to HIV infection seen in approximately 25% of HIV infected persons. Usually is asymptomatic as there are no pain, no symptoms as such. They are present as one or two whitish plaques, usually on lateral margin of the tongue, less commonly of the buccal or labial mucosa or the soft palate. The surface is usually corrugated or folded, giving rise to hair-like position. So hairy leukoplakia. So in the picture, you will see on the lateral side the white patch. This white patch, even this here side, is not oral candidiasis, it is oral hairy leukoplakia. What is associated with loss of Langerhans cells that are there? What is the diagnostic criteria for OHL? The number one, it is on lateral margin. It is white in color, does not get rubbed off easily, appears of hairy leukoplakia, does not refer to any kind of antifungal therapy. What is the treatment of this? So differential diagnosis that can be oral hyperplastic oral candidiasis or condylar micromoneta or tuberous leukoplakia. But the diagnostics we have biopsy, which lead to acanthosis or marked parakeratosis, formation of ridges, areas of ballooning, the cell resembling poliocytes, and dermal inflammatory reaction. Treatment usually not treated because this particular lesion goes away with increase of immunity. So we start with antiretroviral therapy, it responds to that. Acyclovir is given sometimes, or fluoroquinolone is given, but doesn't help. Only giving good kind of ART, including immunity, oral therapeutic will go on. What are the bacterial infections that are there? Common, that is Staphylococcus aureus. It is the most common infection that is there. It can cause various infection in the skin, cellulitis, scabies, herpes ulcer are there. Treatment is what you call antibiotics and pseudomonas bacteria. Syphilis is the new thing that we see right now. And syphilis, we have seen that there are 3 to 9 times more chances of showing clinical examination. Now, syphilis, to get revised the topic, there are 3 types of lesion. Primary lesion, which is painless ulcer becoming painful due to upper infection and giant chancre. Then there is a secondary lesion called as Lewis maligna. Secondary syphilis, which can lead to vasculitis, manifested by fever, malaise, headache, nodules, including plaques, or without epidermolysis and or ulceration of scales. So diagnosis by doing the treponema antibody testing, serum or CSF. Biopsy of the lesion, we DFA, we can stage the material, the lesion can be helpful. Treatment, earlier it was penicillin G that was used. Now we are using erythromycin 500 mg 4 times a day for 14 days recommended. Also, drugs like doxycycline, tetracycline can be used in non-pregnant women. So that should be known. But right now, the company has come up that is giving us penicillin again, so we can use it again with the treatment of syphilis. These are the lesions. This is the oral lesion that we can see on the lips with gamma. Same can be seen on the other part of the body. And this particular thing tells us that syphilis is not over. It is still there. So we have to fight it. Fungal infection, that's the most common oral infection in the HIV population. And the fungus that is more common is candidiasis. Candidiasis is a fungal infection most frequently and probably associated with HIV infection. The incidence correlates with lower CD4 cell count. So any patient asked to open mouth to see a white patch, curdy area, then definitely that is a sign of candidiasis. There are three types of candidiasis. One on the way it is oropharyngeal candidiasis. Usually Candida albicans, that's the most common thing, but we can also have Candida tropicalis or Candida glabrata or Candida cruciate which also occur depending on the geographic condition. Also, mucosal Candida infection result from the impaired cellular immunity. In pseudomembranous candidiasis, that is called a thrush. It characterized by multiple white, non-adherent patches overlying an erythematous, often eroded face. Also, erythematous candidiasis or atrophic form, in which have mucosa exhibits non-specific widespread patchy eczema, most commonly on the hard and soft palate and dorsal tongue, loss of piriform papillae, may be a precursor to thrush. So these people don't have test and they suffer a lot with the. Also, in some, we have angular cheilitis or perlicate, painful fissure at the oral condition. There can be also be a hyperplastic candidiasis characterized by adherent white plaques associated with severe immunosuppression. Oropharyngeal candidiasis may coexist with esophageal candidiasis. Symptoms are stromatopyrosis and stromatopenia. Other manifestations of candidiasis include chronic paronychia, onychodystrophy, and chronic refractory vaginal candidiasis, which we can also have to see to understand. Diagnosis is most common clinical. For microscopy, we can go for KOH strain and also culture is very important. What is the treatment? Treatment is oral hygiene. We give topical neostin or cortisone. In my practice, I use usually IV fluconazole more than oral fluconazole for 14 days works up. People who can swallow or who can swallow that tablet, we also go for oral ibuprofen and pulse therapy. That also helps. See this picture of the esophageal candidiasis in which we see the Candida infection all over the esophagus. And this is the oral candidiasis in which we see the infection in the tongue. There are various variations in the oral candidiasis because most common infections seen in the patient. And if we ask the patient to open his mouth and see the tongue, by just the view or just the picture of the tongue, we can understand that this particular person can have HIV and should be treated for HIV. The interesting topic here is about Kaposi sarcoma. As you know, Kaposi sarcoma is by HHV8. It's a vascular neoplastic disorder, and this particular disorder is more common in the African continent, not in our Asian or Indian perspective. But it is there, we should know. The pathology of endemic KCV HHV8 and can be classified into classical, sporadic, or endemic sarcoma, which is in the most of the African or sub-Saharan Africa. There are four types: benign type, aggressive type, widely disseminated, and lymphadenopathic variant. It can also be seen in children. So it's very aggressive and unpredictable course, and it can be seen everywhere. The clinical presentation gives single or multiple skin lesions. They can be mucosal, visceral, and or lymphatic involvement, particularly in the gastrointestinal tract or the pulmonary parenchyma. The face, trunk, and arms are often affected, though it has high variable distribution. In the oral cavity, if you see, 1/3 of the patient can have the mouth, the palate, gingiva, the most commonly affected. They have stages, that is macule patch, plaque, and nodule, and they can be treated with liquid nitrogen cryotherapy, radiation, or intralesional chemotherapy. Progressive advanced cases have needed systemic chemotherapy like vincristine, and heart is a beneficial role in the treatment of KS. This is the skin lesion that we see with macular patches there on the thing, and this is the classical oral thing that we see. We need to know to distinguish it, because since in the Asian countries we never see Kaposi sarcoma much, but African people do suffer from Kaposi sarcoma. So identifying it and knowing it is the important task in treating HIV in the oral parts of the oral methods of HIV. So when do you suspect HIV? There are 4 key terms or 5 key terms we should know. If the patient having known symptoms, but we cannot identify the cause. So the patient having fever, we cannot identify what kind of fever, which have loose motion, cannot identify more than what we have seen patients who are suffering from more than months and they could not be diagnosed just because they were not tested for HIV. Known case, known disease, but not responding to treatment, having fever with chills, suspecting malaria, not test for malaria, viral fever, but not for treatment can also be one thing. Multiple infection in one system. So if you take the GI system, multiple infection, oral, esophageal, intestinal, and even the anal, then we have that the person can have HIV or skin infections or otherwise. Same infection in multiple systems. Herpes, oral herpes infection, skin, and also the other anogenital part can be there, or different infection in various systems. Also, one other thing that can lead to suspect HIV. As we know, we are going down in number of diagnosing HIV, but still there are a lot of people who are still not diagnosed with HIV, and we need to take care of them, understand them, because if we treat HIV properly, definitely we can control HIV from the whole world. So how do you diagnose HIV? It's very simple. We do HIV antibody test. We used to do ELISA, Western blot. Now we do the antigen antibody combo test. And after that, we conclude. Even we can do the nucleic acid testing and NAT testing. And therefore, we can take viral load of the patient with this particular thing. After diagnosing, we go for treatment. And treatment is very easy. As we know, the ART medications have become more and more simpler and more advanced. And this particular thing, they stop the mechanism of reverse transcriptase, and therefore the viral the virus gets controlled, and we have less number of patients. The list of the ART drugs that we know, we have nucleoside or nucleotide reverse transcription inhibitors called NRTIs, list of them. Then we have NNRTIs, list of them. We have protease inhibitors, a list of them. And now the latest one, the integrase inhibitors, we have dolutegravir, eltegravir. But the number one right now is dolutegravir. Even we have bictegravir, that is also there. The regimes are formed, the regimes are understood, and regimes are given. As per the regime, the treatment goes up, and people are now effective. All these regimes had kind of side effects, but now the side effects are under control. Now the latest regimes have lesser side effects, but more of the what you call treatment resistancy. We can treat the patient in a better way. So we have some kind of side effect, but we can make it. Today, the best drug combination that we use is alafamide and ezetimibe with dolutegravir, or even with dolutegravir, but dolutegravir is single drug. These are the side effects. We can have high self-respiration in some patients in longer run, but we can control it with proper medication and proper assessment. And as we know, if we do that, we can stop HIV. The best way is to prevent ourselves by using protective condoms, condoms, and then if you know understand HIV better, you can treat it. That's how we treat and work up with the HIV infection. So thank you very much.
Thank you so much, sir. Thank you for your wonderful inputs upon the topic that you have shared. We have received few questions from the participants, and with all your due permission, I would like to put it across to you.
Yeah, Batul, no problem.
The first question is, which is considered the preferred therapy for initial treatment of oral candidiasis?
Okay, oral candidiasis, the preferred therapy is we should use antifungal infection. I use in my personal way as a fluconazole. Oral candidiasis, where a person there is also an element of esophageal candidiasis in which the person is unable to swallow the food as well as medication. For that, we definitely prefer them giving an IV therapy of fluconazole, which helps them to get rid of it in a easiest manner. So in the 5 days, if you give fluconazole 200 mg per day, the patient can have it. Also, we can go for what you call oral wash, oral brush, or even we can have some fluconazole liquid also that can also help for treatment of oral candidiasis.
Thank you so much, sir, for answering this question. We'll move to the next question. And the question is, which viral pathogens is the most likely cause of oral carcinoma for the patient who never chewed tobacco or smoked?
Okay. Most common viral pathogen that can be HPV, human papillomavirus, if the person is not having any kind of tobacco, but people who have oral sex or people who are exposed to viruses, then they can have such kind of infection in their mouth. Other than that, other than HIV, I would not comment right now, but oral health or gingival health is important for not having any kind of carcinogen. So, having a proper denture or getting a dentist opinion and also using proper toothbrushes can help you to get rid of any kind of oral infection leading to cancer.
Thank you so much, sir. Thank you for answering this question. We don't have any other questions as of now from the participants, but I would like to thank you, sir, for taking out your valuable time and for being here at our platform and sharing such wonderful inputs with all our viewers. We hope that the inputs shared by you will definitely help them in their daily clinical practices. So thank you so much for that. And at the outset, I would like to thank all the viewers for being here at our platform and staying tuned with us throughout the session.
Thank you very much, Batul, for the opportunity.
Yeah. Thank you so much, sir. With all your last comment, we can conclude the session here for today.
Thank you very much. Thank you.
Thank you, sir. Thank you.